So good morning and welcome to the Dr. Sankaramenon Award session. So just a few instructions. We have 16 presentations today and each presentation is for 7 minutes with 1 minute for questions. As per the rules, only the presenting, there can be no change of presenting author and the results will be announced 2 hours after the session from the office. So all the best. And the first speaker we have today is Dr. Shishir Varghese, who will be presenting real-world outcomes of pars plana vitrectomy with glueless sutureless SF.
We'll start. Yeah. So good morning, everybody, and thank you, KSOS, for this opportunity to for presenting. So I'll be talking on real-world outcomes of pars plana vitrectomy with glueless, sutureless, scleral fixated intraocular lenses. So no conflict of interest. So just a brief introduction. So visual rehabilitation in AFK is a unique surgical challenge, and especially in the absence of a capsular support. So SFILs are ideal because it's placed closer to the nodal point of the eye and a greater distance from the cornea. And many techniques of SFIL has been described previously. So what is the aim of our study? To report the outcomes of pars plana vitrectomy with sutureless intrascleral fixation of three-piece IOL in the ciliary sulcus in patients with aphakia of various etiology. So it was a prospective study. 54 eyes were initially included, but only 40 eyes satisfied the inclusion criteria. And it was conducted in a secondary eye hospital from a period of 2022 April to March 2023. And the procedure was PPV with sutureless SFIL, either as a primary surgery or in combination with lens nucleus or IOL removal done by a single surgeon. And data was analyzed following the data collection. So inclusion, simple, patients with aphakia more than 18 years of age, follow-up of more than 6 months. That was one of the main thing to include the patients in the study, and horizontal corneal diameter should be 11 or less because otherwise the SFIL won't fix. And corneal pathologies are excluded: scleral thinning, uveitis, scleritis, advanced glaucoma, or even gross retinal pathologies or macular pathologies were excluded. So ocular examination before the surgery, vision, slit lamp exam, tonometry, dilated fundus exam, and biometry was done. And this was the surgical procedure. So superior small conjunctival peritomy, yeah, followed by marking the scleral tunnels and with the crescent just making a pocket using the 1.5 millimeter keratome. So two Gabor pockets are created. Then all the three ports are put. SICS tunnel is made superiorly, and then a complete vitrectomy is done. Not just an anterior vitrectomy, but a complete pars plana vitrectomy. No PVD induction. 360 degrees of endo laser is also done. Periphery is checked properly, and then only the IOL is inserted. So using the max grip forceps 25 gauge, one part of the haptic is held and externalized through the scleral tunnel, and then the other haptic is also externalized. Yeah, so other haptic is also externalized by just directly putting it in the vitreous cavity and removing it from the other side of the scleral tunnel using the same max grip. So no two instruments required, only one. You can do in some cases where the pupil was small, we did the same thing with a needle, and you can see a well-centered SFIL at the end of surgery. So no glue also used. Conjunctiva was sutured with Vicryl if required, and all ports removed and no suture. So this was the procedure followed. So the follow-up post-op day 1, post-op day 15, 1 month, 3 month, and 6 months. But the data we have analyzed for day 1, 1 month, and at 6 months. So coming to the basic demographic data, the average age was 68.5 years, 71% were males and 28.2 were females. And blunt trauma was seen in, mild blunt trauma was seen in 9 cases, that is around 23%. So 45% were surgical aphakia, dislocated IOL were seen in 27.5 and dislocated lens was seen in 17.5, and nucleus drop or dislocated nucleus in 10% of patients. So procedure performed: PPV with SFIL 45%, PPV with nucleus lens removal 27%, and IOL removal again 27%. So at 1 month follow-up, the mean uncorrected visual acuity improved significantly, and also there was improvement in the mean best corrected visual acuity. And at 6 months also, between the pre-op and the post-op, there was significant visual acuity improvement, but no difference between the 1 month and the 6 month. So no significant difference between post-op BCV at 1 and 6 months. So, and also there was no significant difference between the pre-op BCVA and post-op uncorrected visual acuity, just that we were just helping them get rid of their aphakia glasses. And coming to the sub-analysis of the BCVA also, you can see the significant improvement in the surgical aphakia group, the dislocated nucleus, dislocated lens, and the dislocated IOL group. And we also just analyzed the refraction sphere and cylinder. Post-operative sphere we saw in two patients who had minus 0.5 and minus 0.75 sphere, but otherwise no sphere. And pre-op cylinder was 1.42, which was measured with a keratometer. And then post-op at 6 months also we measured, and it was average was minus 0.5 cylinder at 6 months. So pre-op IOP was 15.87, post-op day one was 9, which was there was a significant difference, and again post-op at 6 months was only 13.92. So coming to the complications, at post-op day one, the most common complication encountered was dispersed vitreous cavity hemorrhage. At post-op day one, it was also hypotony seen in two patients, and at post-op 1 month, one patient had a recurrent cystoid macular edema, and one patient had post-operative uveitis, which was all managed medically. So coming to the review of literature, if you see eyes, retrospective studies have only been done where PPV has been combined with SFIOL and with varying amount of follow-up, some for 1 year, some for 1 month, and some for 7 months. And you may ask why you are combining PPV. The reason is this. In eyes with SFIL, high chance to develop RD. So 22% of eyes in this study developed retinal detachment. And once you develop an RD, it's very difficult to manage those patients, and there even surgical failure even after the retina is attached, the vision won't improve that significantly. So there are multiple studies where at least in almost all the studies there is had a retinal detachment in most of the studies. So what are the limitations of the study? Our limitation was no comparison group.
Time is over.
Time's up. Okay.
So you did show us one reference of 1000
Yeah.
of 1100 eyes,
Yeah.
but that's also with past plana vitrectomy, right?
No, that is with everything.
So in this study, you
Yeah.
had 22 eyes out of 1300,
Yeah.
which is about 0.2%, 2%.
Yeah. But still, I mean, in those eyes, it was all, they didn't take how we have taken in a
No,
prospective.
no,
They
I
taken all
understand. I understand.
trauma, all those
So
eyes
when you're
also.
saying that in your series there were no retinal detachments,
Yeah.
do you think you have the numbers to actually compare it with, given that the RD rates are
Yeah.
so low?
No, but that is just that's a retrospective of a period of large year. But if you look at these other studies, all the numbers are low. But even in those low numbers, you are having some amount of detachments. So there's eyes with 64 eyes, where 10 retinal detachments are there. I mean, different techniques of
So
SFILs.
do you think that your row of laser
Yeah, I
also?
definitely feel yes. Not just laser, but checking the retinal periphery also.
In literature, what is the longest period
Which one?
for follow-up?
The literature
Yours
longest
is
period
six
was
months,
mine
right?
is 6 months. Only one study has done till 1 year, and most of the studies are all retrospective studies where the follow-up has been erratic. It's always between a period of 3 months to 6 months, because most of these patients, once their vision improves, they get lost to follow-up. Even we have done a study with 250 eyes, but the follow-up is only 3 months, because beyond that, most of the patients they lose to follow-up. Thank you.
Next speaker is Dr. Remy.
Good morning, all. I'm Dr. Hema. I'm presenting a study on origin of fluid in optic with maculopathy, a study in surgically managed patient with scleral plug. So optic pit maculopathy was first described by Ved, and its incidence is 1 in 10,000. And it should be noted that maculopathy can occur from 25 to 75% of patients, which is a notable number. The origin of fluid in optic pit maculopathy is controversial. It is either thought to be from the vitreous due to the negative pressure induced by the VMT, in which liquid vitreous can enter the subretinal space, or from the cerebrospinal fluid, which is due to the direct communication between subarachnoid space and subretinal space. So the aim of our study is to find out the origin of fluid in optic pit maculopathy. The treatment modalities now available is also again controversial. Vitrectomy, plugging of the pit with different materials like platelet, fibrin glue are tried, and juxtapapillary laser, ILM peeling, etc. are tried. Our study is a retrospective study of 13 patients who underwent total pars plana vitrectomy with autologous scleral flap and C3F8 gas from a period of September 2013 to September 2022, and the cases which could not be followed up within 1 year was excluded. A detailed history was taken, slit lamp examination, fundus examination was done, pre-op and post-operative best corrected visual acuity was done, and these data were retrieved from electronic medical records, and 2 senior surgeons has performed the surgery. Coming to the surgery, a brief. We did a 23 gauge vitrectomy. Now we are doing a 25 gauge vitrectomy. A PVD induction was done. A partial thickness scleral autograph was taken from the supratemporal quadrant away from the limbus, and it was plugged into the optic pit. We didn't do an ILM peeling in any case, but PVD induction was done in all cases. C3F8 laminate was done, and prone position was given for 1 week. The OCT analysis was done in raster scan in Spectralis Heidelberg engineering machine of both disc and macula, and pre-op post-op evaluation was done, and statistical analysis was done in SPSS software. There were 5 males and 8 females. All had unilateral disease. Mean age was 35 years. One patient had a retinochoroidal coloboma, and intraocular pressure was normal. The median BCVA pre-op was 636, which improved to 618. And notably, 39% patient had a 4-line gain and 30% had a 3-line gain. The preoperative disc changes, which is a very striking feature we could see, was that a communicating tract, which is already described in literature, was seen between the subretinal space and the perineural space, and other features like hyperreflective spaces were seen beneath the membrane seen on the disc. These are the subretinal, the tract which is connecting the perineural space and subretinal space explained, and we could see the tract is present in almost 80% of our cases. Post-operatively, this is one case, after 6 months of the scleral graft, we could see that the tract is obliterated and the fluid has resolved. This is another patient for whom the scleral graft was dislodged at 1 day post-op, but surprisingly for that patient also, at 1 month itself, this fluid has started resolving. So a mechanical pressure, is it only sufficient than an anatomical closure, is questionable. Coming to the OCT macula, preoperatively, retinal schisis, inner and outer was seen in equal proportion in all cases. Inner retinal fluid first appeared, and outer retinal fluid first disappeared. Also, in cases even for whom that surgery was not done, when we checked retrospectively, inner fluid was the first to appear. Central macular thickness, about 40% cases, 50% reduction was there, and 30%, 70% reduction was there, and it was well correlating with the BCVA gain and decrease of fluid. OCT postoperatively, only 10% patient had normal OCT at 1 year, and 70% had outer retinal schisis. So this is the current concept of fluid origin in optic pit maculopathy. The vitreous Vitreomacular traction causes a negative pressure which can cause a fluid from the perineal space. Do we agree with this? Yes. We could see a tract, and there was fluid which appeared to the tract in the inner retina first. But what we couldn't see was that there was no PVD in any of the cases, and there was no VMT. So we don't agree with the vitreous traction theory. So our humble attempt to explain the origin of fluid in optic pit maculopathy is that a congenital optic pit tract is there between the subarachnoid space and the inner retina. And what causes the fluid to percolate into the inner retina can be anything, either a physiological process like well-defined CSF fluctuation, which can be diurnal or postural, which causes the fluid. And when a
Time is up.
ma'am, the CSF theory is already well explained, ma'am. But the origin of why this fluid is coming to the subretinal space is postulated only, that they are telling it can be without any cause, or can be from the VMT, which causes a negative traction. So we think that since our cases didn't have a VMT, we think that can be any physiological process. For example, can be a CSF fluctuation also. But we are not sure about this is just our postulate. Um, this CSF study and all is done, ma'am, which shows that the potassium and the cellular constitution of this fluid is similar to CSF study, but we couldn't do, we have not done, ma'am.
Good morning. My studies, I'm Dr. Husna. My studies, outcome of corneal collagen cross-linking in progressive keratoconus at 24 months follow-up. Keratoconus is a non-inflammatory bilateral progressive degenerative corneal condition with estimated prevalence of 2 to 3 per 1,000 persons. It causes progressive myopia and irregular astigmatism. Options for visual rehabilitation include glasses as soft and rigid gas permeable contact lenses. Corneal collagen cross-linking is the only treatment modality that arrests its progression. We have evaluated the effect of corneal collagen cross-linking on visual acuity and corneal parameters like pachymetry and keratometry. Aim of the study was to evaluate the effect of corneal collagen cross-linking on visual acuity and corneal parameters like keratometry and pachymetry. It was a retrospective non-comparative study conducted at a tertiary eye care center. The eyes that underwent epithelium of collagen cross-linking for progressive keratoconus between 2018 January to 2019 December. The diagnosis of keratoconus was made based on Kmax value of more than 47 diopters. and by keratometry. Presence of clinical signs like Vox striae, Fleischer ring, and Caesar reflex on retinoscopy, and corneal tomographic measurements that included KMAX, that is steep keratometry, KMIN, that is flat keratometry meridian, and thinnest corneal pachymetry. Topographer used was the anterior segment OCT machine, Visante ASOCT by Zeiss. The staging of the disease was based on the standard Amsler-Crumake classification. The progression of keratoconus was defined as presence of two of the following: a decrease in subjective or objective visual acuity, either uncorrected visual acuity or best spectacle corrected visual acuity attributed to keratoconus, an increase of more than or equal to 1 diopter in KMIN or KMAX over the preceding 12 months. Preoperative data collected included age, gender, uncorrected visual acuity, the best corrected visual acuity, the thinnest pachymetry, the maximum K and the minimum K values. During follow-up visits, we took the data of uncorrected visual acuity, best corrected visual acuity, thinnest pachy, Kmax and Kmin. The change in keratometry, pachymetry and visual acuity after 2 years were compared with the preoperative values. And we excluded all patients who missed any of these data. The procedure was done based on Dresden protocol, that is central 9 mm epithelium was removed by mechanical debridement. Riboflavin 0.1% in 20% extran was administered topically every 3 minutes for 30 minutes. The cornea is exposed to UVA light for 30 minutes at an irradiance of 3 milliwatt per centimeter square at 5 centimeter distance from cornea. During UV exposure, isotonic riboflavin was administered every 3 minutes. After the procedure, BCL was applied, which was removed 2 days later when epithelial defect was healed. The statistical analysis was done using STATA version 12, and variables were described as mean and standard deviation. Then students t-test paired and unpaired, and Fisher's exact test were used for analysis. P-value less than 0.05 was considered statistically significant. Results showed a total, we had a 92 eyes of 65 patients. The mean age was 23.43 plus or minus 4.8, which 67 eyes belonged to males and 25 eyes to females. 49 eyes belong to stage 1 keratoconus and 34 eyes to stage 2 and 9 eyes to stage 3 keratoconus. The results showed that an improvement of uncorrected visual acuity in logMAR units from 0.7 plus or minus 0.28 to 0.61 plus or minus 0.26. Best corrected visual acuity also improved from 0.4 to 0.28, and Kmax improved from 49.38 to 49.07 plus or minus 3.45, and Kmin improved from 45.65 to 45.19. Pachymetry decreased from 52.82 to 41.41. All the values showed statistical significance. The number of eyes achieving best corrected visual acuity of 0.3 logMAR unit or better significantly increased from 54 eyes, that is 58%, to preoperatively to 72, that is 78, almost 80% at 2 years, and it was found to be statistically significant by Fisher's exact test. We can see almost 80% of eyes had a visual acuity of 612 or better, that is 0.3 logMAR unit after the procedure. 50 eyes, that is 54% eyes showed an improvement in uncorrected visual acuity after collagen cross-linking. The procedure was well tolerated by all patients and except for the mild postoperative pain, which was resolved in 5 days or less. And there was no serious complications such as corneal scarring, infection, and corneal decompensation. The studies showed in a review by Mahrat, it was found to be improvement in visual acuity and keratometric values after the procedure. Another study, they also got improvement in the visual acuity, and we have obtained statistically significant visual acuity in both uncorrected and best corrected visual acuity after 2 years following the procedure. In another study, they didn't get a statistically significant improvement in decrease in the Kmax. None of our cases showed progression at 2 years. Strength of our studies that we were able to collect data from a good number of patients. We did only 2-year follow-up study. A longer follow-up will aid to determine whether the UCVA continues to improve. The conclusion is corneal collagen cross-linking stabilizes and even improves uncorrected visual acuity in patients with mild to moderate keratoconus. Our study proved the stability of Dresden protocol over a period of 2 years. Thank you. No, general consultant. Yes, pachymetry. there was statistically significant decrease in the corneal pachymetry. From yes, after 2 year we have a significant decrease in the corneal pachymetry. Actually, we took the 2 year data only, and which was compared to the preoperative values. Uh, yes. Actually, progression was not documented at 2 year follow up. Yeah. Yes. We have only 9 patients. We have steep care more than advanced keratoconus more than 55. Yeah. Minimum 48. Mm. Yeah. Yes. Okay.
Good morning to one and all. At the outset, I would like to thank KSOS for giving me this opportunity. Can anti-segment OCT biomarkers predict the future recurrences in RCS patients? So RCS patient is a chronic, relapsing, severe, painful condition, and till date, nobody is happy to see an RCS patient in their OPD because there's no way to predict in whom we will have more recurrences. So the aim of our study was to study the ASOCT biomarkers in these patients and to study the capability of these ASOCT biomarkers in predicting the future recurrence in RCS patients. So this was a retrospective study, and all patients with RCS were enrolled, and at the OPD level, history was taken on the cause of initial insult, the duration, time gap, and the frequency of recurrences. And based on the history of frequency of recurrences, patients were grouped into frequent recurrent groups, that is patients who complained of at least one episode a month, or rare recurrence group, that is patients who complained of an episode at least every 2 to 3 months, or complained of only limited or fixed number of recurrences since the initial insult. All patients underwent slit lamp examination, ASOCT scanning, and epithelial mapping. So the RCS area was marked in the OPD level, and a clinical diagram was drawn, and this area was then sent for ASOCT scanning, and additionally an epithelial mapping of the entire cornea was done, and area of RCS thickening, as seen here, area of epithelial thickening was delineated as the hotspot on the epithelial map, and we tried to look at whether this hotspot corresponded to the clinical diagram which was drawn in the OPD level. So ASOCT changes in RCS patients are seen more in the superior layers, that is in the layer of the epithelium, the epithelial basement membrane Bowman's layer complex, that is the BMBM, and the stroma. These are the common changes that we looked at. That is the epithelial changes that we commonly noted were epithelial hyperreflectivity, epithelial detachment, epithelial edema, and intraepithelial hyperreflective inclusion bodies were seen in a few. And the BMBM changes that we noted were, as you can see with the blue arrow, a BMBM line which is seen in the other areas was absent in the area of RCS. And in some patients, the BMBM layer was hyperreflective in the area of RCS. And coming to the stromal changes, there was anterior stromal haze noted in a few. And additionally, in the epithelial mapping, as you can see with the pointed area, the area of epithelial thickening in the area of RCS was denoted as the hotspot in the study, and we looked at whether this hotspot corresponded to the clinical diagram drawn in the OPD. So 36 patients were enrolled, and more than 52.8 patients complained of symptoms for more than a year. And 69.4% of our patients fell in the frequent recurrence group. And fingernail was noted to be the most common cause for injury as the initial trauma. And we looked at our ASOCT changes. Majority of the patients, that is more than 70% of the patients, were noted to have, in both the groups, were noted to have epithelial and BMBM changes, and stromal changes were noted only in a few. So we went ahead and compared these changes between the frequent recurrence and the rare recurrence group. And even though epithelial and BM changes were seen in majority, only BMBM changes were noted to be statistically significant between the two groups. So what does this mean? This means that the BM changes is more frequently seen in the patients complaining of frequent recurrences, and the occurrence of this on ASOCT could probably indicate that this patient will have more recurrence in the future. Then we looked at the ASOCT epithelial map changes, and the hotspot was seen in more than 90% of the patients with RCS. And not only was it seen, it also corresponded to the clinical diagram which was drawn in the OPD. But when we compared it between the two groups, there was no significant difference noted between the two groups. So it indicates that this could just delineate the area probably, but not be a predictor of future recurrence. So RCS, as we know, is a chronic relapsing condition, and it is painful, and a fingernail injury noted in our study corresponds to other studies as well. And our ASOCT finding of BMBM changes is a non-invasive way of what we already know, that the culprit is at the epithelial basement membrane adhesion complexes. And ASOCT changes have been studied in the past. This is a study where they looked at the ASOCT changes in an acute and chronic patient. In acute, as we can see from the first picture, they saw epithelial breaks, whereas in chronic patients, they saw these intraepithelial inclusion bodies, loss of BM at the spot. But ours is the very first study to compare these changes between the two groups, and also try to identify a change which is more commonly seen in a frequent recurrent erosion group. So though in our study, both epithelial and BMBM changes were noted in more than 70% of the patients, BMBM changes was the only change which was seen more commonly in frequent recurrence group. And this could probably in the future delineate patients with higher recurrence rate. What does this signify? This signifies that till date, slit lamp examination is the only way that recurrent corneal erosion patients are followed up. And this is highly inadequate in prognosticating the patients. Our study agrees with that ASOCT can delineate the area of RCS well, but this cannot predict the future recurrences. So historically, slit lamp examination was used to document epithelial changes, but our study has proven this is highly inadequate in prognosticating patients with RCS. And imaging has revolutionized many treatment, and it helps in better prognostication. So we would like to move from slit lamp examination to epithelial mapping to delineate the area well, and on ASOCT scanning, try to identify whether it's epithelial BMBM or stromal changes. And if BMBM changes are noted, go in for an early surgical intervention rather than waiting. The limitation of our study is that it's retrospective nature and it's small sample size, but this is just a pilot study and a prospective arm is underway. This is the first study to categorize the predictors of recurrence using modern imaging, and we would like to take this further. This is my references. Thank you so much.
That's very interesting. I, so, in terms of the time that you took the image, how long was it after the erosion happened?
So all these scans have been taken at acute presentation when the patient presented to the OPD, and this is not.
So was it-
the prospective arm is underway.
Yeah,
This is
so,
the
so
retrospective.
was it all on the same day?
Yes, sir. All on the day of presentation.
All on the day of
On the
present-
day of presentation.
So how did you? I mean, you're talking about hyperreflectivity, and
Yes,
you're
sir.
talking. Was there any way you quantified that in the sense, because it's a subjective variable? So was there
That's
any way you quantified that?
That's an interesting suggestion, sir. Probably we will look into it in the prospective arm. We didn't really quantify it. We just looked at its presence and absence only at this point.
So I think, see, because that is where the whole thing becomes a little
Okay.
tricky. You should quantify it, or you should have a set of standard images with which you compare it.
Yes, sir. We would look into that prospective arm. Sir, at this point, we have just looked, these are just at acute presentation. In the prospective arm, we are planning to look at the different modes of treatment. We have,
You
we
not
have-
looked at the post-op.
at this point in this particular study, not yet, sir. Yes, ma'am. Can I have the slides, please? I'll just show it to you, ma'am. 1 second. in the age, mean age was 35.7. Thank you. Thank you so much. Yes, ma'am. No, ma'am, this whole yeah, this for the study because we wanted it to be as reproducible as possible. Something like a classification like this can be done in an OPD and can also be reproduced by others. We just wanted to keep it simple based on the history alone and not complicate it too much, just to make the study more reproducible. Thank you.
Good morning, everyone. I'm Dr. Chandrakant. The title of the paper is to study the outcome and complication in 100 eyes by phacoemulsification of high myopes with cataract. A retrospective study for 100 cases and for 3 years. Myopic eyes, as you all know, is an enigma because of its inherent structural variations. So here operating on a cataract in such cases is a challenge. I present here 100 cases, a retrospective study for 3 years. I'm Dr. Chandrakant. Material methods, 100 eyes with myopia having a cataract selected in the study. It was a retrospective study for cataract for 3 years. The selection of patients, here you can see the majority of the patients come in the age group of 30 to 50. This is a demographic table. Preoperative status, if you see here, the majority of the patients were in the group of 6 by 18 and 6 by 24. Refractive power, if you see, majority of the patients, -6 diopters in 14 eyes, -5 in 12 eyes, -8 in 16, and -9 in 21 eyes. To start with, the preoperative assessment as routine for any routine cataract surgery. That's a preoperative checkup, refractive dynamic and static refraction, IOP measurement by applanation, lacrimal syringing to know the patterns of the lacrimal duct. Then you have a detailed slit lamp examination to see the corneal status, endothelium, the cataract, any subluxation, any dislocation, such things and all. Fundus examination wherever possible. B-scan, whenever the fundus is very hazy to see the posterior segment. And optical biometry to see the IOL power calculation. Dilated fundus examination was done, and 17 eyes had lattice with retinal holes, which were barraged before the cataract surgery was done. A minimum of 1 month was kept before it was subjected to cataract surgery. But here, only one patient had a 1 month duration after the laser. Almost majority of the patients were waited for almost after 3 months. This is a phaco procedure. I'm showing the video. A bent keratome to do 2 millimeters incision. Before rexis, you are doing a staining with the methylene blue, then a side port entry. A large capsular rexis, around 5.5 to 6 millimeters diameter. Hydrodelineation and hydrodissection is in progress. Then phacoemulsification, I did a phaco chop. Use minimal power, all power, vacuum, and aspiration, keep in lower parameters. Once the nucleus is removed, the epinucleus is removed with this IA probe. Then once the cataract is removed, the implantation of the intraocular lens into the capsular bag. Remove the viscoelastic, then self-filling incision. Hydration of the wound to self-fill the incision. Intraoperatively, we had one I had iridodialysis noticed that was not noticed on the table. After 1 month only, we could notice it at the periphery. There was a small iridodialysis which didn't hamper the IOL position, whatever it is. One I had posterior capsular rent at the periphery when the last bit of nucleus was removed. No vitreous loss was encountered, so the IOL could be placed in the capsular bag. Post-operative, one eye had a retinal detachment after 18 months after the surgery. Vitreoretinal surgery was performed. This eye had undergone barrage laser for multiple lattices with holes 3 years before the cataract surgery. One had a mild descended IOL that did not hamper any vision. This is the post-operative visual status. At the end of 3 years, almost 32 eyes had 6x6. 26 eyes had 6x9. 31 eyes 6x12. 9 eyes had 6x18, and 3 eyes had 6x24. This 6x24 patients with the last 6x18, 6x24, almost 11 patients had severe choroidal myopic degenerations in the posterior pole. This is the flow chart there. Later postoperative complication we noticed was 3 eyes had post-capsular opacity. One, it was thick at 12 months, second at 20th month, and third at 30th month. All underwent YAG laser capsulotomy with precautions, keeping a minimum YAG laser power. One had retinal detachment after 18 months, which underwent RD surgery. To conclude, phaco emulsification of cataract in high myopic eyes can be surgically managed by taking precautions like using lower parameters like phaco power, vacuum levels, and aspiration days. These modifications should be kept in mind before doing this procedure to get optimal visual outcomes. These are my references. Thank you. SRK2, I think. Yes. Then with the optical biometry, we had a Barrett calculation. Then based on that, we put end-rock lenses. Yeah.
Because
Final it was Barrett.
SRK2T usually won't give. Barrett gives a good.
Barrett was used.
Yeah.
All cases we use Barrett. Although we have optical, we do a optical this thing, but then finally we go to the Barrett and then only we implant the lenses.
Intraoperative, any issues you had just for the like iris retropulsion?
That is there. So we will have to take precautions. As I said, the parameters are kept lower, and no one's more tolerance. So except the only one patient when they had a small nuclear bit which ruptured the posterior capsule of the periphery. But luckily for us, we noticed it early so that we couldn't. There was no vitreous loss, and we could keep the intraocular lens in the back. That the particular patient had no problems at all. Post-operatively, there's a good visual record, no issues at all. Jay? Not exactly. Not exactly, because I got a little, state-of-the-art phaco machine. I don't want to name them, actually. So in that, yes. And again, there's a myopic mode in that, the myopic mode is there. So we do that. Welcome.
Good morning, everyone. So I'll be presenting my study on the comparative analysis of iris glow lens implantation. So the objective is to analyze the visual outcome, the intraocular pressure profile, complications, post-retropupillary iris glow lens fixation in complicated cataract surgery-induced aphakia, and also to compare the results of retropupillary iris glow lens fixation in eyes with and without anterior vitrectomy, and also to compare the results in eyes with and without a surgical peripheral iridectomy. So the hypothesis is that iris glow lens implantation has emerged as one of the most safest and preferred method to correct the surgical aphakia in complicated cataract surgery patients. And studies have shown that anterior versus retropupillary fixation yielded similar results and complication profile. However, the retropupillary fixation is more advantageous because it respects the physiological location of the lens within the eyes. So routinely, anterior vitrectomy is performed by most of the surgeons during a retropupillary iris glow lens prefixation. However, there are few surgeons who may not do that if the anterior vitreous phase is undisturbed or there is no vitreous in the pupillary margins. However, what is the chances of IOP spike, the secondary inflammation, recurrent uveitis, visual prognosis in such cases without an anterior vitrectomy is not studied yet. Also, there are few surgeons who implant an iris claw lens without a surgical PA. However, there are no studies comparing the effect of PA in the long-term IOP profile also. So, when we did a literature search, we found that a comprehensive literature literature review yielded that most of the studies were comparing iris claw lenses with anterior chamber IOLs and SF IOLs. And the results, early studies were mainly comparing the results with anterior pupillary iris claw lenses rather than retropupillary iris claw lenses. So, there is an increased need for more studies focusing on the retropupillary iris claw lenses. Primary outcome is the long-term visual outcome and the complication profile in this RPICL implanted patients in comparison of the IOP and complication profile in with and without anterior vitrectomy, and also the chances of IOP rise and complications in eyes without a peripheral iodectomy. So it was a retrospective study from July 21 to 2023. We included all complicated cataract surgery patients with intraoperative posterior capsular rupture, sonal dialysis, pre-existing dialysis with at least a 3-month of follow-up. We excluded all cases with gross iris abnormalities, iris new vessels, and uveitis and pre-existing glaucoma. So all the demographic data was collected. All the patients underwent a complete ophthalmological evaluation, including best corrected visual acuity, slit lamp examination, A scan, central corneal thickness, intraocular pressure, and a complete fundus evaluation. Categorical and quantitative variables were expressed as frequency and mean plus standard deviation respectively. Independent t-test was used to compare the quantitative parameters between the characters. So we had a total of 36 eyes of 36 patients. Mean age was 68. Group A, that is one with anterior vitrectomy, included 18 eyes, and Group B, that is the one without an anterior vitrectomy, included 18 eyes. Mean best corrected visual acuity is 1.6 unit, which improved to 0.33 at the end of 3 months in the total study group. Mean IOP of the study population was 15 millimeters of mercury. Best corrected visual acuity in our study improved significantly in both the groups after surgery and was remarkably higher than the baseline. There was no statistically significant difference in the best corrected visual acuity between the two groups during each follow-up visit. The mean intraocular pressure was highest on day 1 and it was around 22 millimeters of mercury. The mean postoperative IOP at the end of 3 months was 14. An IOP greater than 21 millimeters of mercury was noted in 10 patients in Group A and 11 patients in Group B at the first week postoperatively. However, there was no statistically significant difference between the observed IOP between the two groups. Complications, when we compared the complication, the Group B, that's the group without an anterior vitrectomy, did have a higher rate of postoperative transient IOP rise, recurrent iritis, pupil ovalization than the Group A, but the difference did not come statistically significant. Disenclavation of iris claw lenses happened in case 1 patient in Group A, whereas in 2 cases in Group B. And complete ICL dislocation also happened in 1 case in Group A. Significant corneal edema was actually more in the Group B, that is the eyes without an anterior vitrectomy. Coming to the surgical PA, primary surgical PA was actually done only in 14 eyes. Rest of the eyes, the surgical PA was not done. However, the need for a secondary laser PA due to an uncontrolled IOP postoperatively happened only in 3 eyes. So we conclude that there is no statistical significant difference in the IOP profile between the two groups with and without PA. So this is in discussion. Study by Crystalline et al. And Dalby et al. Claim equal efficacy of RPICL when compared to secondary IOL. And a study by Madhivanan et al. Also claims equal efficacy and safety for RPICL. However, they stated that the incidence of iritis, transient IOP rise, ovalization was all higher in case of RPICL implantation. So our study also showed that RPICL implantation is a safer and simpler method. But the BCVA and IOP profile is comparable with SFIOL. In cases with complicated cataract surgery and with very less vitreous disturbance or no anterior vitreous phase disturbance, it is actually safe to do iris claw lens implantation even without an anterior vitrectomy. Postoperative IOP profile, post-retropupillary iris claw implantation with and without iodectomy was similar. Thank you.
Yeah, so you said that the intraocular pressure profile was similar, right?
Yes, sir.
So you also said that 3 patients required a YAG PI for uncontrolled IOP. Was
Yes.
that in the vitrectomy group or in the non-vitrectomy group?
It was in the non-vitrectomy group, sir.
So you had 18 patients in the vitrectomy group and 18 in the non-vitrectomy group.
Yes, sir.
You did surgical PI in 14 patients.
Mm.
Was this in the vitrectomy group or non-vitrectomy group?
That
Even assuming that it's equally
Yeah.
distributed,
Mm.
that means you had 11 patients who did not have a surgical PI in the non-vitrectomy group, out of which 3 had an acute IOP spike which needed a YAG PI.
yes,
So
sir.
3 out of 11 is 30%. So when you look at mean values and compare this, your study is not powered to pick up the differences. One. Second, you are trying to, the only aim of your study, of doing the PI is to prevent a pupillary block.
Yes, sir.
So you actually have to look at the rates of pupillary block in both the groups.
Yes.
And the rates of pupillary block are very high in your study, it's 35%. So concluding that, doing a PI is not of any use is actually misleading when you interpret it like that.
Okay.
What were the situations where you are not you did not do anti-vitrectomy?
Sir, actually, most of the cases where this black, brown cataracts, very hypermature type. So in those cases, actually, even though the lens came with the bag and sometimes there was SEDI also, we found that the anterior vitreous space was not disturbed. There was not much vitreous coming
Any
out.
modification of iris claw implantation you did in such cases? Because what happens, even the implantation of iris claw itself can disturb the intravitreal space.
Yes,
Because
sir. But actually, in our cases, like
that's
it's
what
done
I'm
by senior
asking.
surgeon.
That's what I'm asking. Any modification you?
No, it was done by senior surgeon. But
Okay.
not me.
Okay. Thank you.
Yes, sir.
Sorry. Good morning. My study topic is clinical profile of endogenous endophthalmitis in a tertiary eye care center at Malappuram. So we know endogenous endophthalmitis is a severe form of ocular inflammation with a source of pathogens situated within the body, and it accounts for 2 to 8% of all endophthalmitis. There are many systemic risk factors for the same, diabetes being the most common. There are many studies on exogenous endophthalmitis but very few on endogenous. The aim of my study is to study the clinical profile, risk factors, microbiological profile, and treatment taken by patients who presented with endogenous endophthalmitis. This was a cross-sectional study conducted in the Department of Ophthalmology in the last year. The age of patients, the demographic profile of patients, their underlying systemic infections, pre-existing medical conditions, the source of infection if possible, the treatment taken, and the final outcomes were collected. Endogenous endophthalmitis was diagnosed clinically in the presence of significant vitreous inflammation with or without anterior segment inflammation. In cases where the fundus view was hazy due to corneal opacity or a cataract, a B scan was done to confirm the diagnosis, and MRI was done in stable patients to rule out intracranial extension. So all patients were given intravenous antibiotics, and the panophthalmitis patients who did not respond needed an evisceration, and endophthalmitis patients were given intravitreal antibiotics. Those who responded were repeated intravitreal. The intravitreal antibiotics were repeated. If no response, they were referred for a vitrectomy. These are my results. We had 8 patients, 5 females and 3 males in the age group, average age group of 61. The youngest was a 45-year-old male patient. And the most common comorbidity was uncontrolled diabetes. The source of infection varied, which I'll be coming to in the coming slides. The most common presentation was defective vision followed by pain. The left eye was predominantly involved. Half of the patients had, that is, 4 patients had no perception of light at presentation, and 5 patients had panophthalmitis. So we had 5 patients with panophthalmitis. This was the first patient who was a 61-year-old uncontrolled diabetic on dialysis who presented with fever and panophthalmitis and a no PL vision. Since she was not responding to intravenous antibiotics, she had to undergo an evisceration, after which her systemic condition drastically improved. The blood cultures, the evisceration specimen, as well as the dialysis catheter tip showed positivity for Pseudomonas aeruginosa. So that is most probably the source of infection. And this was another 69-year-old patient admitted in the ICU who developed panophthalmitis with a no PL vision, and she succumbed to her illness. The probable source was the lung because she was admitted for bronchopneumonia. She was again uncontrolled diabetic. The third patient had no comorbidity. She presented with panophthalmitis and a no perception of light vision. In order to prevent intracranial spread, an early evisceration was done. The blood cultures were positive for streptococcus, although no particular source could be identified. This was our fourth patient who was a diabetic on chemotherapy for AML, was diagnosed to have mucormycosis of the sinus with periorbital extension, and the involved eye went into auto-evisceration within a week. This was another patient, diabetic, who was admitted for UTI, and the blood cultures were positive for streptococcus. The presenting vision was perception of light. We had advised an intravitreal injection, but the patient went elsewhere for a second opinion, later developed panophthalmitis, and the eye had to be eviscerated. This was another 65-year-old diabetic patient, again developed UTI after catheterization. He had a perception of light, but we gave him a dose of intravitreal antibiotics and referred him, but he did not go. The vision has dropped to PL negative, but he is asymptomatic otherwise now. The blood and AC cultures are negative. This was the 45-year-old male patient with no comorbidities who had a liver abscess and an endophthalmitis in the right eye. The presenting vision was hand movements plus. He went elsewhere for the liver abscess drainage. Prior to that, we had given him 1 dose of intravitreal antibiotics. But after the liver abscess was drained, his vision had dropped to PL negative, after which evisceration was done from there itself. The causative organism from the liver abscess specimen was entamoeba, but the evisceration specimen details were not available. This was an 56-year-old male, again with no comorbidities, who had a bee sting on the finger. He was very sure there was no sting near the eye, and the vision was PL plus, and he was given intravitreal antibiotics. But since there was no improvement, he was referred for a vitrectomy. He underwent early vitrectomy with lensectomy, which improved his vision to 6/12 with aphakic correction. So this is roughly what the patients had undergone. We had 5 patients with panophthalmitis, all of which had poor prognosis. And this coming to the discussion part, the mean age group in our study was 61, which was comparable with other studies. Laterality, we had more of a left eye involvement. The most common comorbidity was uncontrolled diabetes, which was seen in the studies by Pillai et al. And the most common foci in other studies by Pillai et al. Was UTI, which was also in our study. But in Western studies, it's usually IV drug abuse. The blood cultures, we had 37.5% positivity, higher in Western studies. And the aqueous and vitreous tap we got a dry tap in vitreous, and aqueous samples were negative, but higher rate of positivity was there in other studies. The most common organism was found to be equal for fungal and bacterial. We did not have enough numbers to come to a conclusion, but we had 1 fungal and 2 streptococci and 1 pseudomonas from blood cultures. And to conclude, diabetes was the most common risk factor, uncontrolled diabetes, and panophthalmitis at presentation had very poor prognosis. The culture positivity was also associated with poor prognosis. Any vision drop in a critically ill patient should be looked with caution. These are my references. Thank you.
Did all patients also get IV antibiotics?
Sir?
Did all patients also
Yes,
get
sir.
IV antibiotics?
All were given intravenous antibiotics.
So the ones who are in the ICU were based on a blood culture, or was it being given empirically?
That patient had bronchoalveolar lavage positivity.
And it was
Acinetobacter.
based on a culture, or it was
Culture.
it was based on culture?
Yes, sir. A vitrectomy we had referred, intravitreal antibiotics we had given, and No surgery. This is endogenous end of. So, all exogenous were excluded actually. Surgery within 1 year also were excluded. Any cataract surgery. Yeah, we had more of panophthalmitis, which was not, I mean, there are only very few studies, only one patient with panophthalmitis during the COVID time and all, but we had more number of panophthalmitis, but uncontrolled diabetes was the most common cause. Yeah. All were very uncontrolled, mainly on dialysis and all, and dialysis catheter tip is one source of infection which we usually miss in dialysis patients. Okay.
Visual outcome and SDOCT parameters predicting visual outcome following cataract surgery in patients with type 2 macular telangiectasia. First symptoms of MACTEL, like reading problems and distorted central vision, usually occur in the 5th or 6th decade when cataract also becomes visually significant. Hence, prediction of visual improvement following cataract surgery in these patients becomes important and challenging because defective vision may be contributed by both in varying proportions. There are many studies which assessed SDOCT parameters in MACTEL. However, there are only very few studies which dealt with SDOCT findings before cataract surgery and their correlation with postoperative visual outcomes. Aim of our study was to assess the visual outcome and to evaluate the SDOCT parameters predicting visual outcome after cataract surgery in patients with type 2 MACTEL. It was a retrospective observational study of 62 patients who underwent cataract surgery from our registry of 745 patients with MACTEL. Definite diagnosis of MACTEL based on gas and bloody classification, which was further substantiated with multimodal imaging, good SDOCT image before cataract surgery, visual acuity measurement before and 1 month after cataract surgery were our inclusion criteria. Exclusion criteria were defective vision due to other retinal causes or media opacities, concurrent ocular surgical procedures along with cataract surgery, and history of previous retinal laser treatments or intravitreal injections. Patient demographics were noted, and best corrected visual acuity before and after 1 month after cataract surgery were measured using Stendhal's chart, and this was converted to log mark for statistical analysis. 1 month post-op, a detailed ophthalmic evaluation was done to rule out causes that can compromise vision after cataract surgery, like posterior capsular opacification, cystoid macular edema, etc. All patients underwent color fundus photography, SDOCT, and multicolor imaging with confocal blue reflectance. SDOCT parameters tested for correlation with postoperative visual acuity included internal limiting membrane drape, inner and outer retinal cavitations, collapse of inner retinal layers, isolated ellipsoid zone loss, that is subfoveal or extrafoveal, continuous ellipsoid zone loss, that is subfoveal and extrafoveal, retinal pigment clumps, subretinal hyperreflective membrane, and central foveal thickness. This SDOCT picture illustrates the typical findings of collapse sign, ellipsoid zone loss, cavitation, ILM drape, retinal pigment clump, and SHRM. Central foveal thickness was measured using spectralis and was defined as the average thickness of macula in the central 1 millimeter in patients who did not have fluid or SHRM on OCT. All patients underwent phacoemulsification and implantation of foldable acrylic monofocal intraocular lens. There were no intraoperative complications. Statistical analysis was carried out using appropriate tests, and a p-value of less than 0.05 was considered statistically significant. Coming to results, out of a total of 88 eyes of 62 patients were studied. The mean preoperative visual acuity was 0.78 log mark, that was 636, and the mean postoperative visual acuity was 0.28 log mark, that was 612. Out of 88 eyes, only 24 eyes had a vision less than 612 and 14 less than 618, and only 4 eyes had a visual acuity less than 636. In the first patient with external limiting membrane ellipsoid zone loss, subfoveal cavitation, and ILM collapse had a visual acuity of 612 and 6 after cataract surgery, and the second patients with external limiting membrane ellipsoid zone and outer retinal loss subfoveally with collapse of inner retinal layer had a visual acuity of 6, 6 and 6. And the third patients with a large subfoveal outer retinal cavitation had a visual acuity of 636 and 10. And the last patient who had retinal pigment clumps and SHRM had a postoperative visual acuity of 660 and 18. Univariate analysis of SDOCT parameters showed significant association of collapse of inner retinal layers, continuous ellipsoid zone loss, retinal pigment clumps, and SHRM to be associated with a visual acuity of less than 612. Compared to these, ILM drape, retinal cavitations, and isolated extrafoveal ellipsoid zone loss were less likely to cause a visual acuity of less than 612. Patients with retinal pigment clumps and SHRM had 7 and 8.5 times higher risk of having poor visual outcome compared to those who did not have them. The mean central foveal thickness in patients with 612 or better postoperative visual acuity was 175 microns, and in those with less than 612, it was 150 microns. Preoperative visual acuity depends on both the grade of cataract and the changes of mactel, but final visual acuity after cataract surgery is a reflection of severity of changes secondary to mactel only. In our study, visual outcome after cataract surgery was generally good in patients with mactel. Out of 88 eyes, only 24 had a vision less than 612, 14 less than 618, and 4 less than 636. We defined BCVA worse than 612 as poor visual outcome. So in the poor visual outcome group also had reasonably good visual acuity like 612 parts and 618. Many of these patients had significant OCT changes before cataract surgery, based on which we had delayed surgery for a while, but when done at a later date, their visual acuity improved significantly. This means that many of our patients, in spite of having SDOCT features predicting for visual outcome, actually had relatively good vision, that is better than 636 post-cataract surgery. 27% poor visual outcome was observed because we kept a stiff cutoff of 612. Some patients with even subfoveal EZ loss also had reasonably good visual recovery. Our findings were similar to those in the literature. The major limitation of the study was that grading of cataract was not done in this study. To conclude, visual outcome was good after cataract surgery in a majority of patients with type 2 mactel. Many patients with advanced SDOCT changes had significant improvement in vision postoperatively. RPC, collapse of inner retinal, continuous EZ zone, and SHRM were associated with less than 612 vision after cataract surgery. No patients had worsening of visual acuity. Hence, cataract surgery should not be deferred in patients with mactel based purely on significant SDOCT changes. Thank you.
So those who improved the vision, even though there was OTC changes, did you analyze them, and how much functional damage was there? Means it will give us to how to counsel the patient, and it will help.
So actually,
The vision, the patient who had less vision, that you analyze.
yeah, this mainly 4 characters, sir. One is rectal pigment clumps and subretinal hyperreflective membrane and ellipsoid zone loss and collapse of inner retinal layer. These were the 4 important prognostic factors predicting visual outcome after cataract surgery. And actually, these represented very advanced stages of the disease, like foveal photoreceptor atrophy. So these were the late stages of the disease. These were associated with very poor visual recovery. No, we didn't analyze that. We didn't analyze the pre and post. We analyzed only the visual outcome and preoperative SDOCT predictors of visual outcome after cataract surgery. Preoperative predictors. We didn't analyze the SDOCT after surgery, but none of the patients deteriorated after cataract surgery. And we had a fundus examination at 1 month to rule out other causes like cystoid macular edema. And there was, by clinical examination, there was no worsening.
Correct. Suppose you have some based on that, can we predict that patient will get a good vision? Because some of your patient had a good vision.
Yes, sir. So this,
can you help us to counsel the patient?
yeah, suppose there is a cavitations and ILM drape. These were associated, isolated extrafoveal EZ loss. These were associated with better visual outcome after cataract surgery.
Did you look at
Yeah, we didn't analyze the near vision, but there was definitely, why this study was conducted is many of even my patients, see, they had advanced, see in this example, advanced looking changes on OCT. Actually, we delayed surgery for a while, and 2 or 3 patients I did surgery under the written informed consent that there won't be any improvement in vision. But to my surprise, they improved to 6.9 and 6. So then 2-3 patients, then I operated a little more confidently. Then they also surprisingly, the 1 or 2 patients improved to 6 in spite of having significant SDOCT changes. So that then I asked my colleagues, they all had similar experience. So that's the time I thought we should conduct a study, at least to create an awareness that we should not delay surgery based just on SDOCT pictures, because to our surprise, most of them improved. Not done. But that was the limit. Yeah, but that was a limitation. But then the post-op visual acuity mainly depends on the MACTEL, doesn't depend on the cataract. Looking at the next time. No, one thing was that, yes, a cataract definitely will definitely do surgeries. Yeah, in the OCT. That's all.
Good morning, all. Good morning, all. I'm Dr. Reshma, talking on multimodal imaging in central serous chorioretinopathy, a descriptive study. Central serous chorioretinopathy, or CSCR, is characterized by neurosensory detachment with accumulation of subretinal fluid because of RP dysfunction or hyperpermeability and thickening of choroid. Aim of our study is to evaluate the role of multimodal imaging in eyes with chronic CSCR and comparison of fluorescein angiography, ICG angiography, and OCT angiography features in chronic CSCR. In multimodal imaging, various imaging techniques done in a single platform, here spectralis HRA plus OCT, and the imaging techniques include fundus color photography, multicolor imaging, fundus autofluorescence, optical coherence tomography, fundus fluorescein angiography, indocyanine green angiography, and OCT angiography. It's a prospective descriptive study conducted from December 2020 to April 2022. 30 eyes of 25 patients diagnosed with chronic CSCR were studied. All the patients underwent a comprehensive examination, including the imaging techniques. Coming to the results, 30 eyes with chronic CSCR were studied and majority were males. OCT is the best technique to demonstrate subretinal fluid, pigment epithelial detachment, focal and diffuse RP alteration, and followed by multicolor imaging and fundus color photography. Subretinal fluid was the most common finding in OCT, followed by pigment epithelial detachment and focal RP alterations. And the other findings include brush border pattern, double layer sign, dipping sign, and vacuole sign, RP microribs. Majority of the patients showed hyperautofluorescence in fundus autofluorescence, and it's a better imaging technique to demonstrate descending tracts and diffuse RP atrophy. The most common pattern of leakage in FFA was ink blot pattern, followed by smokestack pattern. The OCT findings corresponding to the leakage, site of leakage in FFA include fibrinous exudate, vacuole sign, dipping sign, and vascular flat irregular PED. And the OCT angiography findings include dark spot, white spot, and tangle pattern. In ICGA, dilated choroidal vessels were seen in most of the patients, which indicates hyperpermeability of choroidal vessels. The most common OCT angiography finding in CSCR was dark area, which was seen corresponding to the site of SRF in OCT. And the other findings include dark spot, white spot, and tangle pattern. In 2 eyes, hotspot in ICG were seen corresponding to the site of abnormal network in OCT angiography, which was suggestive of CNVM. Coming to the discussion, in study conducted by Lee et al., Hyperautofluorescence were seen in the site of SRF in 8 eyes, and discrete dots with hyperautofluorescence in 10 eyes, which was corresponding to the site of subretinal precipitate in OCT. Similar findings were obtained in our study also. Descending tracts in chronic CSER without RP atrophy were short and broad, but with RP atrophy were long and narrow, which was consistent with the study finding of Lee et al. In a study on the double layer sign conducted by Chablani and Mandadi, concluded that hyperreflective space within the double layer sign is associated with CNVM. In our study, 5 eyes showed hyperreflective space within the DLS. Of these, 2 eyes showed CNVM. And in study conducted by Daruich et al., hyperreflective dots were seen in the choroid in 72% of the eyes, and it disappeared with the resolution of SRF. And in our study also, we noted hyperreflective dots in 63% of the eyes in choroid. So it indicates that in addition to increased thickness, qualitative changes in the choroid can also cause, choroid may also indicate an active process. In study conducted by Rajesh et al., he found an association between vacuole sign and steroid intake. In our study, vacuole sign were seen in 5 eyes, but none had history of steroid intake. The most common pattern of leakage in FFA was ink-blot pattern. Similar findings were obtained in study conducted by Shahid et al., Baig et al., and Peiken et al. In study conducted by Zujikawa et al., they reported hyperpermeability of the choroidal vessels in 93% of the cases in and around macula, vascular arcade, and optic disc. In our study, most of the eyes exhibited dilated choroidal vessels, which indicate hyperpermeability of the choroid vessels in multiple choroidal areas. In study conducted by Aburva et al., smokestack leak in ICJ site was seen corresponding to the site of leakage in FFA, and it is seen in association with FIPET and dipping sign. In our study also, we noted leak in ICJ site corresponding to the site of leakage of FFA, most associated with vascular FIPET and vacuole sign, and we termed it as double leak. In study conducted by Samir et al., they found vascular networks as tangle pattern in 50% of eyes in octa. We found 6% of eyes with tangle pattern in octa, which were corresponding to the site of leakage in FFA and hyperfluorescent spot in ICJ. So we concluded that multimodal imaging techniques play a crucial role in evaluation of chronic CSER, and Octa was able to identify abnormal choroidal flow, making it most effective modality for detecting CNVM in eyes with chronic CSER. These are my references. Thank you.
If you had to use any one instrument, which one would you use? And if you had to use a second instrument in addition to that, which one would you use?
One is OCT, next is Octa.
And with that, you think you will be able to get most of the pathology?
Yes. We are using. Mm. No. Thank you.
Good morning. Today I'll be presenting on effectiveness of transscleral diode laser cyclophotocoagulation in refractory glaucoma. So the aim of the study is whether diode laser is an effective tool in in lowering the intraocular pressure in refractory glaucoma. So this is a retrospective study where all patients of 2021 to 2022 were reviewed regardless of the glaucoma type or stage, and patients less than 6 months of follow-up were excluded from the study. So after taking an informed consent, the diode iridex machine with the parameters of 1500 to duration of 3000 and giving giving peribulbar block, the G probe was kept perpendicular to the limbus, and superior and inferior quadrant was diode laser was applied at avoiding 3 o'clock and 9 o'clock position, and the parameters were adjusted just to avoid a pop. At the end of the procedure, 0.1 ml of dexamethasone was given. The intraoperative documentation and postoperative care included topical steroids, anti-glaucoma medication, and oral non-steroidal anti-inflammatory drugs and carbonic anhydrase inhibitors were given for a short course. During the follow-up visits, the visual acuity assessment, intraocular pressure, anterior segment evaluation for complications were analyzed, and the complete success was defined as IOP less than 22 without any glaucoma medication, and qualified success was IOP more than 22 with glaucoma medication. Failure was defined as IOP more than 22 with maximum anti-glaucoma medication, any hypotony related cases, and need of additional cyclodestructive procedure, and increase in the number of anti-glaucoma medications after 4 weeks. The secondary outcome was the visual deterioration. That is, if there is a persistent drop in the visual acuity for more than 3 months, and all the data was statistically analyzed. So out of the 110 eyes reviewed, the mean age was 57.84, and all the patients had undergone local anesthesia. Only 2 patients had general anesthesia, and the maximum number of cases who had underwent diode was the neovascular glaucoma, and of the 110 eyes, 6.36 eyes had previously failed glaucoma surgery, and 27% had retinal surgery, and one patient post micropulse neovascular glaucoma had undergone diode at 2 months post-operatively. Then among the 110 patients, only 56.3% had 6-month follow-up, and 40% had 1-year follow-up. And most of the patients, diode was done in 93.6% patients was for pain relief and reduction in IOP. The visual acuity outcome at 1 year, there was an improvement in visual acuity in 5 patients. It was unchanged at for 30 patients, and decrease in visual acuity in 9. There is a statistical decrease in the IOP, that is from 39.7 to 19.5, and the average number of anti-glaucoma medications was reduced from 3.03 to 2.42 at 1 year follow-up, which is not statistically significant. Complete success was seen in 28% eyes, 46% showed qualified success, and failure was seen in 24% eyes. The most common complication here was the decreased visual acuity. Then coming to the discussion, mainly diode is done for eyes with poor visual potential and painful blind eyes. And complications like pain, phthisis, and prolonged inflammation has been reported. Various studies, and our study shows that diode is having a significant IOP reduction and favorable complication profile in refractory cases of glaucoma. Then in our study, the power used was 1500, and the duration was 3500. So as a result, there was a decrease in the post-procedural inflammation in the early post-operative period. And the POP was also titrated by 250 millivolt, Therefore, it minimized the tissue coagulation accompanying the post-operative inflammation. This is a study done by Sklov et al., which is comparable to our study, and they showed a success rate of 77.3, whereas our success rate was 74%. In Sklov et al., the IOP reduction was 18.7. In ours, the IOP reduction was 20.17. The loss of visual acuity, that is in 9 eyes, it is basically due to the end stage of the disease. And 2 patients had phthisis in our study. That is basically due to the scleral thinning which we had. And our results suggest that for such cases, the titration of power and duration of laser energy, this potential complication could be largely avoided. The limitations of our study is the retrospective nature, and proper documentation of post-procedural pain and inflammation was not correctly documented, and several patients defaulted in the follow-up visit. To conclude, diode laser can be used in cases of refractory glaucoma in candidates with poor filtration surgery. These are my references.
You had 2 patients with phthisis, right?
Yes, sir.
So what was the underlying cause in those patients? And says, was it NVG? What was the reason for the glaucoma in those patients?
Both the patients were the pediatric patients, basically. They had several areas of scleral thinning, but we had avoided those areas, but still they developed this one. One was a traumatic cataract, and other one is an aniridia case.
So you were doing 360 degrees,
Yeah.
basically. Yeah, so that's one of the, so normally most of the time when we do the diode for the first time, we treat 180 degrees.
Thank you.
And we usually don't, your settings are low, 1.5 is okay, but the 3 milliseconds is actually pretty high. 3000 milliseconds, 3.5 seconds is fairly high. Your phthisis rates of 2 out of 44 are actually not low. That's about 5%.
Yeah.
In the reported literature nowadays, it's around 2%. And considering that you have a significant dropout rate, the rates may actually be a little higher. So 360 degrees as primary diode, especially in somebody who's never undergone a glaucoma procedure before, is maybe a little sort of more aggressive than what is normally recommended.
Have you repeat in any patient?
No, we didn't repeat in any patients. It was 1 week, 1 month, 3 months, and 6 months, and 1 year follow-up. It had fallen down to 44 eyes. Thank you.
A very good morning to one and all present here. Today I'm going to present on the management of subluxated capsular bag IOL complex. I am Dr. Raisa Paul, and it's not moving. Okay. Can I start? Okay. So IOL subluxations can be of varying degrees. Minor degrees of subluxations are noticed. Moderate or severe will be presenting with gross reduced diminished vision, diplopia, raised IOP, and inflammation. So the symptomatic subluxations are to be managed surgically. Either you have to fix it to the sclera, or you can exchange it with iris claw. SFIOL is the most preferred. It can be either sutured or without sutures. So the objective of the study, this is a retrospective study. Here we studied the demographics, etiology, the assess the management methods, clinical outcomes in terms of visual improvement, and the safety and efficacy of the surgical techniques also was studied. The materials and methods, the 11 eyes of 11 patients who were symptomatic, and who presented from the duration of July 2022 to 23 were included. And here 11 patients were there. For 4 of them, in situ fixation was done, and for 7 of them, IOL exchange with anterior vitrectomy and SFIOL was placed. So data collection included the logMAR BCVA. Initially, it was measured in Snellens and converted logMAR. Duration since primary surgery, lens status of the other eye, then the ocular predisposing factors, preoperative biometry, OCT, and endothelial cell count, the surgical techniques, and postoperative refraction at 6 weeks, and the complications. An in situ fixation method, either if there is a closed loop, it is done in case of a closed loop foldable IOL, or if there is a C loop with fibrous capsule. Here, 2 scleral flaps are made 180-degree apart, and AC maintenance is used. And using an ionoprolene, which is double armed, one end is threaded, it is introduced from the scleral flap, and from the other end, 26 gauge needle, which docks in the ionoprolene, is taken out through the closed loop of the haptic, and it is exteriorized from one of the scleral pockets, and it is tied. The suture goes under the scleral flap and it's not exposed. Next slide. So here, this is a picture just to show that the first needle goes above the IOL, and the second one is passed through the fibrous capsule or within the closed loop of the haptic. Okay. So it goes into the Hoffman pocket, and it is used to bury the exteriorized knot so as to prevent the suture erosion. Now coming to the IOL explantation group, here as in SICS, superior frown incision is made, and the anterior chamber maintenance is used to avoid using OBD. The subluxated IOL is dialed into the anterior chamber using Sinskey hook. Explanted using McPherson forceps, the anterior vitrectomy was done. And here 2 partial thickness scleral pockets, Hoffman's pockets, were made, and which was made at 3 and 9 o'clock positions, and long straight needle was used, which was passed which is passed underneath one flap 1 millimeter from the limbus, while a 26 gauge needle is passed underneath the second flap, and the needle of the suture is exteriorized through the opposite flap. The middle of the suture, it is in the middle of the suture, it is pulled out from via the superior tunnel, and it is cut into 2, and it is threaded through the eyelet of this SFIOL, and the IOL is introduced via the main port, and it is placed beneath the iris, and the sutures are tied beneath the scleral flaps, and it is not exposed. Now coming to the CMT flex SFIOL, in few patients we use CMT flex SFIOL. Here the technique is the same, but the T haptics are buried in the pockets, which eliminate the sutures. And for this, customized 23 gauge forceps is used for exteriorizing the haptics. This is a video showing the placement of the CMT flex via the main port. The CMT flex is loaded, and it is injected using a cartridge, and the T haptics are exteriorized using special forceps, and it goes under the scleral flaps, thus eliminating the need of sutures. So coming to the results, here the mean age was 73, and although the range was between 60 to 89 years. The lens status other eye was pseudophakic, and the duration between the primary surgery was 11 years, And corrected distance visual acuity in the study I was 0.91, whereas which corresponded to 6 by 36 of Snell lens. The cause for subluxation was studied. Intra-opsonular dialysis was seen in 2 patients. Spontaneous subluxation was seen in 8, and trauma was a cause in 1 patient. And ocular predisposers which were found in our study were pseudoexfoliation and axial myopia. Other associations were primary open-angle glaucoma, and ERM was seen in 1 patient. The pre-op ocular investigations biometry average was 22.59, and specular microscopy it was 1785. OCT macula was within normal limits in 10 patients, whereas in 1 patient it showed an epiretinal membrane. Now, surgical intervention was done. In situ was done in 4 patients, and 7 patients SFIL was placed. The okay.
So, which was the most, which had the best outcomes in these 3 groups?
So, in this future SFIOL patient had a better outcome, but we cannot say because there was a very marginal difference. When it comes to the safety of the procedure, none of the patient lost 2 or more than 2 lines of visual acuity, and efficacy was found to be like 6 by 9 was reached by 91% of the patients.
Why did you decide it was a subluxated bag complex, right?
Yes, sir.
So why wasn't the entire bag fixated in every case? What are the reasons to do an SFIL or explant and SFIL in some cases?
In case of closed loop haptic, when closed loop haptic was there, it was fixed. Or when there was a well fibrous capsule, then also it was fixed. In absence of such things, or more than the zonular dialysis was more than 180 degrees, in those patients it was not, SFIL was placed. Yes. Video presentation. Okay, thank you.
Good morning all. My free paper is on clinical, serological and imaging characteristics of optic neuritis in a tertiary eye care center. Optic neuritis or inflammation of the optic nerve is a frequent cause of acute optic nerve injury in children and adults. Though multiple sclerosis is reported to be the most common etiology in Western literature, its association in Indian literature is reported to be very low. Understanding of optic neuritis has changed significantly with the introduction of newer imaging modalities and serological testing for myelin oligodendrocyte glycoprotein antibody and neuromyelitic optica antibodies. However, there are few unanswered questions about the trend or pattern of optic neuritis in Indian scenario and how similar or different it's from the Western population. So here we aim to correlate the clinical course with serology and imaging features in patients with optic neuritis presented in a tertiary eye care center in South India. So all the patients who satisfy the criteria for optic neuritis from the period of July 2018 to 2023 with at least 1 month of follow-up were included in our study, and those with the secondary causes were excluded, and those who could not complete at least 1 month of follow-up were excluded. It was a retrospective observational analysis. All patients underwent detailed ophthalmic evaluation along with optical coherent tomography, macular GCL analysis, visual fields and visual evoked potential, MRI brain with orbit with contrast, and serology for anti-NMO and anti-MOG antibodies. Once the diagnosis is confirmed, all patients receive IV methylprednisolone according to body weight for 3 to 5 days based on response, followed by a tapering dose of oral steroid. All patients receive neurology consultation for lumbar puncture, specifically to look for CSF oligoclonal bands. Coming to the result, total number of patients in our study was 44. The mean age was 32.48 plus or minus 16.21 years. Females outnumbered, and unilateral cases was more common than bilateral. BCVA at presentation was worse than 6 by 16, 45.5%. But by 1 month, it improved to better than 612 in 89.7%. RAPD was present in 97.7% at presentation, However, by 1 month, 51.28% still had persisted RAPD. Color vision improved significantly by 1 month. Fundus showed at presentation there was a predominance of papillitis followed by retrobulbar neuritis. But at 1 month, 56 patient had normal disc, but 41% had sectoral disc pallor. VEP P100 latency improved significantly by 1 month. OCT showed at presentation 66% had peripapillary RNFL thickening corresponding to the papillitis, and at 1 month 90.62% had a peripapillary RNFL thinning. Macular ganglion cell analysis showed there was 64.28% had a normal GCL at presentation. However, 35.71% had GCL thinning at presentation, indicating in a previous attack or subclinical attack. But by 1 month, 93.54% had GCL thinning, indicating axonal damage. Visual field could not be done due to almost all patients because of the poor vision at presentation. However, by 1 month, almost all patients had scotomas. In MRI brain and orbit, predominant findings were T2 hyperactive optic nerve and CNS demyelination, and anti-MOG antibody was positive in 25%, but none had positivity for NMO antibody, and CSF oligoclonal band was positive in 15% of cases. MS optic neuritis and MOG optic neuritis predominated in our study, with 18.18% had MS optic neuritis, with clinical feature was similar to the previous reported literature. However, fundus had equal incidence of retrobulbar neuritis and papillitis in our study. MOG optic neuritis accounted for 15.9% in our study, with mean age at presentation was slightly higher than MS patient and almost equal involvement of male and female gender. And we had a 28.5% of bilateral presentation, and there was recurrence of around 28.5%. 25% of our study population was pediatric optic neuritis, with age ranging from 4 to 17 years, with female outnumbered. Less than 10 years had a bilateral presentation in our study, and more than 10 years had unilateral presentation. Papillitis was more predominant, and MRI had 36.36 having demyelination, and 9.1% had acute disseminated encephalomyelitis. Visual acuity improved significantly by 1 month. Discussion. Age of presentation and female preponderance in our study was similar to that reported by ONTT studies and other studies. Papillitis was the most predominant presentation, with 65.4% having disc edema, which was in contrary to what reported in the Western literature. RAPD was present even after 1 month and remained a sensitive indicator of previous attacks of optic neuritis. 35.72% had GCL thinning at presentation, indicating a subclinical attack or recurrence in the past. T2 hyperintensity and demyelination was the most common imaging finding, and MOG optic neuritis and MS optic neuritis were more prevalent in our population. To conclude, RAPD and OCT biomarkers remain the sensitive indicator of previous attack of optic neuritis even after 1 month. Papillitis was the most frequent presentation. MS optic neuritis and MOG optic neuritis were more common, and macular GCL thinning and in STOCT and T2 hyperintensity of optic nerve in MRI were the most common imaging finding. Limitations is small study population and short follow-up. Thank you.
You had no NMO positivity.
One, NMO patient usually will have a lot of systemic involvement, so they will go to the multi-specialty hospitals prior. So ours is a tertiary eye care center, so they be one of the possibilities.
See, when you have got fairly good documentation and everything put together, what you should try and do is you should try and look for risk factors for poor prognosis. You can do a multivariable analysis to do that. So instead of just presenting only the characteristics, you can actually, you have enough data to do more.
Yes, sir. We are planning to do that.
Okay.
To extend it. Why? I mean, that's how we. No, in person, no association with the gender involvement. Yeah, we'll do that.
Morning. My topic is papilledema versus pseudopapilledema, a qualitative analysis of the swollen optic nerve head by OCT. Disc edema could be due to multiple factors, and differentiating a pseudopapilledema from early papilledema can present a diagnostic challenge. Absence of the spontaneous venous pulsations, which is common in papilledema, may be even present in 10% of the healthy patients. So usually we diagnose pseudopapilledema if there is an exposed optic disc drusen or a buried disc drusen which is seen on B scan, or hyperautofluorescence on fundus AF, or absence of leakage on FFA. And with the OCT, we always go for a quantitative analysis where we look at this where we look at this increase in peripapillary thickness, which is seen in papilledema, and we think that that is absent in pseudopapilledema. But most of the cases, it's not the same. You can see some amount of peripapillary thickness even in these cases, and again, we are confused whether we are dealing with a case of pseudopapilledema or early papilledema. So there are enough clinical and experimental evidence to show that there is biomechanical forces in papilledema, which can be substantiated by the posterior scleral flattening, which we see in MRI in cases of raised intracranial tension, or the distension of the optic nerve sheath, or the resolution of the papilledema that we see after optic nerve sheath fenestration and the occurrence of choroidal and circumpapillary folds. So keeping this in mind, we did this study, and the aim of the study is to determine how the increased intracranial pressure affect the peripapillary subsurface structures of the neural canal opening of the optic nerve head at the level of the retinal pigment epithelium and the basement membrane using OCT. So it was a cross-sectional study which was done in the Department of Ophthalmology in a quaternary institute in Kerala from July 2022 to December in 6 months period. Patients with papilledema, pseudopapilledema, normal controls were included, and the grading of papilledema was done clinically by Frisson scale, and patients who had cataract, retinopathy, or optic atrophy were excluded from our study. So how did we confirm pseudopapilledema here? The presence of spontaneous venous pulsation. We have a good neurology department, so if the presence of normal MRI and lumbar puncture, or a longitudinal stability of the optic nerve head clinically, and by OCT looking at the peripapillary thickness, at least 2 visits if it's stable over 6 months, and confirmed optic disc druseness. So this is what we looked at. Qualitative analysis, we looked at this RP basement membrane by doing an HD OCT through the optic nerve head, and the central axial image is taken, and we looked at the direction of this line, which is considered negative if it's away from the vitreous, and it's considered positive if it is towards the vitreous, and the angle was measured at the temporal and nasal part of the OCT. So this is how we measured. We drew a line parallel to the unaltered RP basement membrane furthest away from the optic nerve head, and another line parallel to the altered one. And the angle measurement was done with the software Imager, which automatically measures it. We did by 2 observers calculated and measured it, and the inter-observer change was also noted. So these are some of the representative cases. Here you can see that the line is turned inwards, which is positive. Here it is outwards, which is negative. Here it is outwards, again negative. So the results, we had 43 patients in our study, 36 eyes in papilledema, 36 in normals, and 14 in pseudopapilledema. Mean age of our study group was 32.07. We had 27.9% males and 72.1% females. Age and gender distribution among the 3 groups didn't show any significance. So here you can see that the mean age is almost similar in the 3 groups, and the most common age group was 20 to 40. Grading of papilledema, we found in our study, most of the patients were in the early papilledema group. So now let's look at the RP-BM angle. You can see that in the papilledema group, 69.4% had positive angulation in the nasal and 72 in the temporal quadrant. And it's interesting to note that none had a 0 angulation. I forgot to mention that the angles between +5 and -5 is taken neutral. In pseudopapilledema, the positive was seen only in 14.2 in the nasal and 0 in temporal. And similarly in the normals too, and the difference between the 3 groups was statistically significant. The mean inward RP angle was +9.6 temporally and +11.69 nasally. Inter-observer agreement was good. There was a kappa value which shows a measure of agreement of 0.78 with no statistical significance between the 2 observers. We also compared between the early papilledema and pseudopapilledema, which is the area where the confusion happens. And again, we saw that there was no negative angulation in both the nasal and the temporal quadrants in the grade 1, and pseudopapilledema was the same. And the difference was statistically significant. So this study demonstrated that HD-OCT is able to detect subtle deformation of the subsurface structure, architecture of the optic nerve head and peripapillary region,
And papilledema causes an inward bowing of the RP-BM layer at the NCO, which is not typically seen in normalized or pseudopapilledema. The normal lamina cribrosa is already slightly bowed backwards. In a study which was done by Cooper, Smith et al., they did a similar study, but they did between papilledema and normals, and they found 69% of the patients having positive angulation. Another study Anand et al. Did, which they looked into the angulation difference post-LP, and they found that the positive angulations changed to negative post-LP in papilledema patients in 5. So the degree of the structural stiffness depends upon a lot of properties like size, shape of the scleral canal, and scleral thickness. So that may be the reason why some of the patients in our normals and pseudopapilledema had a positive angulation. So to conclude, RPEBM would help to differentiate between early papilledema and pseudopapilledema, thus avoiding further investigation. It's a useful adjuvant to the study and management of patients with papilledema and pseudopapilledema. These are my references. Thank you.
Did you calculate the sensitivity and specificity of the
So
test?
because we have 3 values at positive, neutral, and negative, we couldn't do it as such, but we did between positive and negative. So when we did like that, we found 100% sensitivity with the positive angulation and 80% sensitivity. But because it's not that valid here, that's why I didn't present it, because we had 3 values. 0, we couldn't put in positive and negative. So those values which are taken as flat was put in neutral.
Okay, but you could have calculated an area under the curve with the 3 values to see what happens.
Fields were done in most of the patients, ma'am, but it was not included in the study. So some of the patients showed this optic nerve disc in case of papilledema, blind spot enlargement, and construction of the visual fields. And pseudopapilledema, most of the time it was normal. So pseudopapilledema patients which are included in the studies were all confirmed pseudopapilledema patients. We also looked at the causes and everything, but for this presentation, I put only the RPBM angulation. Actually, when the disc edema is massive, then the membrane may not be that clear. So we have taken only those ones which are clear, and we have included most of them as early papilledema ones. The early papilledema, it's very clear, but when you go to the later ones, it's difficult. Thank you, sir.
Good morning all. I'm Dr. Savya. So my topic today is combined topography guided photorefractive keratectomy with accelerated collagen cross-linking in keratoconus, the outcomes and safety profiles. So collagen cross-linking arrests the progression of keratoconus by inducing the formation of inter and intrafibrillar collagen crosslinks. The major drawback of the procedure is astigmatism because it does not correct the underlying irregular astigmatism. So topography guided photorefractive keratectomy and attempts to correct this irregular astigmatism by regularizing the surface of the cornea. So if this is a irregular keratoconic cornea, what it does is it superimposes a spear on the surface of the cornea and causes ablation of the tissue in between, resulting and helping in regularizing the surface of the cornea. So the aim of the study was to evaluate the visual, refractive, and the topographic outcomes in patients with keratoconus who underwent combined topography-guided photorefractive keratectomy with accelerated collagen cross-linking in a tertiary eye care institute. So the materials and method, this is a retrospective study, interventional study. The inclusion criteria included patients who underwent topography-guided accelerated collagen cross-linking during the study period, and a minimum of 1 year follow-up was there. Exclusion criteria was a history of previous ocular surgeries, any coexisting corneal pathologies, pregnancy and lactation, and who had less than 1 year follow-up. So the methodology followed was uncorrected visual acuity, the best corrected visual acuity, the manifest refraction, detailed slit lamp examination of the anterior and posterior segment, the corneal topography, the ASOCT was taken preoperatively and also during the follow-up period in 1 month, 3 months, 6 months, 1 year, and the last follow-up. The procedure that we followed, that a topography guided PRK plus accelerated collagen cross-linking, is as follows. After topical anesthesia, a transepithelial phototherapeutic keratectomy was performed with excimer laser at 6.5 mm optic zone at a depth of 50 microns. And after this, topo-guided photorefractive keratectomy was done at the central 5.5 mm optic zone at a maximum ablation depth of 60 microns, aiming at a 70% of cylinder or a residual stromal bed of 350 microns, followed by mitomycin C application 0.02 percentage, 1 second for each micron ablation, followed by copies irrigation by saline. This was followed by installation of riboflavin drops 0.1% solution for 20 minutes at 2-minute intervals, and then UVA exposure. The accelerated protocol that we followed was Athens protocol with a UV exposure of 9 milliwatt per centimeter square at a total irradiance of 5.4 joules per centimeter square for a period of 10 minutes. The total duration of the procedure was about 30 minutes. The statistical analysis was done with the SPSS software version 26, and the normality of the data was found out with Kolmogorov-Smirnov test, and based on the presence or absence of normality paired t-test or Wilcoxon sign rank test was done, and a p-value less than 0.05% was considered statistically significant. So coming to the results, the total number of subjects were 63, among that males outnumbered the females, and total number of eyes were 70. The mean age was 23, and the mean follow-up period was 16.45 months, ranging from 12 months to 26 months. The preoperative UCVA and BCVA showed statistically significant improvement from 0.815 to 0.341 and 0.718 to 0.163 respectively. And the cylinder the mean cylinder also showed statistically significant decrease throughout the follow-up, from minus 3.148 diopter to minus 2.47 at the last follow-up. The mean spherical equivalent increased statistically significant over the follow-up from minus 2.8 to minus 3.3 diopters. The topographic changes, the Kmax, the steep cornea, and the steep K1 and flat K also showed decrease during the follow-up period. But among that, the steep maximum keratometry, the Kmax, and the steepest keratometry curvature, the K2, was statistically significant. And there were no complications. Discussion. A statistically significant improvement in the visual acuity was seen at the last follow-up, as in the previous studies reported in literature. The cylinder also showed a statistically significant decrease. In our study, it was minus 3.148 to minus 2.59 at almost 16 months. And De Rosa has also given a similar report of from 3.63 to 2.04 at 2 years. And in our study, it can be seen that this is a comparative refractive maps of a patient who underwent TGP-RK with C3R. So here we can see that this is this is a pre-op picture, and this is a post-op refractive map. And the pre-operatively, we can see that the values at the pre-operative map are actually on the flatter side are actually becoming steeper, and the steeper part is being flattened post-operatively. So as a result of this, there was a shifting of the center of the cone from the peripheral part to the center part. So this might be a reason for our study showing a spherical equivalent increase over the follow-up period, contrary to the other similar studies that has been published. So no complications were observed post-procedure in any of the patients, which indicates the safety and effectiveness of the procedure. The limitations of the study is that it is a retrospective study, and higher order aberrations were not assessed. So in conclusion, our study suggests that a combined topography-guided photorefractive keratectomy with accelerated collagen cross-linking results in better visual outcomes with reduction in astigmatism without complications, and it is a safe and effective in treatment of keratoconus. These are my references. Thank you.
What stages of keratoconus were included in this study?
We had gone up to the Amsler-Brumlich criteria grade 3 up to. Our main criteria was the pachymetry. There should have been a sufficient pachymetry of more than 350 microns for undergoing the TGP-RK part. Maximum ablation, we wanted a minimum residual thickness of 350 microns. So we have limited the ablation to as far as 60 microns, not more than 60.
Are there any surprises? There are no surprises.
No, surprises were not there, but Some cases, there was loss of lines in some cases, probably due to the haze. It has been likely
No,
to
surprises in terms of topographic changes and as well as.
no refractive surprise as such was there.
Okay. What laser platform is this?
Allegretto wavelight excimer laser.
Allegretto 500.
Yes.
Is it a Contura or?
Contura base.
Okay. Okay.
Thank you.
Good morning, everyone. My paper is on screen time and outdoor activities, unraveling their impact on childhood myopia. No financial interest. As we are all aware that myopia is emerging as a public health issue. Public health issue is one that can affect the health of the population, which can either be newly appearing or has been there for some time, but is now rapidly increasing in incidence. So, Brainhold and Vision Institute has estimated in 2010, 1.9 billion of the global population were myopic, out of which 70 million were high myopic. And these numbers are projected to rise to 50%, that is about 5 billion, and 1 billion, that is 10%, respectively, by 2050. So that means by 2050, one person out of two will be a myope, and one person out of 10 will be a high myope. So this is the time to act. In India, the second most populated country in the world, with 41% of our population being less than 18 years, and there are not many studies from India in this regard, and this particular publication by Agarwal et al., here we have a forest plot. Here from 1980s to early 2000s, the prevalence is less than 8%, but the many publications came in the last decade, the prevalence is almost touching 30%. So as we know, myopia is a multifactorial disease. There is an interplay of factors like genetic, environmental, and microenvironmental factors which contributes to myopia. So in the recent times, because after the COVID pandemic, we knew that environmental factors play an important role in the onset as well as progression of myopia. So with keeping this in mind, we formed our research question: is there actually an association between environmental factors with myopia? So our objective was to find the association between screen time and outdoor time with myopia. This is a cross-sectional study, observational study, done in 51 eyes of children with myopia more than 0.5 diopter from 1st April to 31st May in a secondary eye care center in North Kerala. So we looked into the history, determination of screen time. Parents were asked about the total time spent on television as well as mobile in hours. Determination of the outdoor activity, the number of hours the child is playing outside home was taken as outdoor activity. Age appropriate vision testing, squint evaluation, anterior and posterior segment evaluation, and a cycloplegic refraction were carried out. The mean relative spherical equivalent was calculated as the sphere plus half of the cylinder. Coming to my results, the total screen time was 3 plus or minus 1.5 hours, and outdoor time was 2.76 plus or minus 1.579. So this scatter plot shows there is an association between total screen time and outdoor activities in hour, as most of the dots are coming to the towards the line. And the Pearson's correlation, when we calculated, the screen time had a more association with myopia with a p less than 0.01, sorry, and the outdoor activity with myopia p less than 0.5. Coming to discussion, exposure to natural light and distant objects when outdoors may help in preventing or delaying the onset of myopia. We don't know whether it is the outdoors high light intensity, spectral makeup, and light wavelengths which may boost up the retinal dopamine release and or circulating vitamin D levels, which prevents the eye from elongation. And highly significant positive correlation between myopia and screen time could be attributed to increased near work and reduced outdoor time associated with the screen-based activities. Studying the underlying mechanism behind the link between screen time and myopia, which has not yielded a single distinct process. And as we know, COVID-19 pandemic has changed the lifestyles of not only children but also the adults. Online classes during the lockdown not only led to increased screen time but increased near activity and less outdoor time. Even though the classes are shifted to offline, the lifestyle continued, and there is a surge in myopia and onset as well as progression in the last 3 years. Limitations of my study, it is important to consider what children are doing on screens. But educational content may have a different effect compared to a recreational or social media use. The study may establish a correlation, but it might not improve a causation. So myopia could vary depending on the geographic area as well and climatic factors also. So that this study has not included. So I would like to say the need of a multifaceted approach to address the childhood myopia by promoting outdoor activities and moderating the screen time. And this is essential for parents and healthcare professionals to consider these factors when addressing myopia, preventing and management in children. So what was known is, previous studies have shown that faster childhood myopia progression in younger age at myopia onset independent of other risk factors. And increased screen time and less outdoor time activities were found to have a major impact on myopia onset as well as progression. What my study adds, our results suggest that there is a strong association between these two factors, and it has a valuable reference regarding early life screen use and outdoor activity, and their potential associations with myopia, like a state like Kerala where children go to school very early at 2 years of age, which might interest the clinicians and these researchers alike. So in future, longitudinal studies with a larger sample size to look for other risk factors and correlation between parameters like axial length and biomechanics also would be needed, and so that we can modulate and customize the treatment for each and every patient. Thank you. Yeah, everywhere it is.
What was the actual coefficient of correlation for the two parameters? Because you just put the p-value, it didn't actually give us the value.
Screen time, I think it was minus 0.04, and the other one was 0.5, I think, sir. I'm not very sure.
0.5.
Yeah.
See, minus 0.04 is a very small amount. And if you look at the R square, the coefficient of determination will be even less than that.
Okay.
So then that accounts for hardly, I mean, maybe 15% of not less, 0.15% of the contribution towards myopia.
Okay.
The problem is, since you've done a cross-sectional study, you're just looking at the amount of myopia at that time. It's not looking at the rate of progression. And when you present the correlation, it's always better to give the value rather than the p-value, because that tells you the quantum of the effect.
Okay.
And as long as the p-value is less than 0.05, the rest doesn't matter.
Okay, thank you, sir. No, we didn't do that because getting vitamin D in a child will be very difficult. Yeah, I agree, sir. So in future, we would like to do, actually this sample size is only 51, so we may have to do a more larger sample size with more follow-up and also progression as well. This is just a cross-sectional study.
The problem with vitamin D is I don't think anybody knows the normative levels in children. And definitely the normative levels in India are not what it is in the West.
Okay. Per day. Means average, total with average. No, we have just asked the parents about the total screen time in a day, and if the some parents were telling they means in the during the day school days there will be only 1 hour, but during weekends they yeah. So mean we have taken. Yeah. Okay. Yeah. Okay. 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 Thank you, ma'am.
Good morning, sir. Should I start? So I'm presenting a Down's trend of ROP incidence in India. It's a unique neonatologist-based survey. ROP is a vasoproliferative disorder of retina seen in premature infants and is leading cause of preventable childhood blindness throughout the world. From our database of ROP screening at Girdhara Institute, we have observed significant decrease in incidence of both total ROP and treatable ROP from 2015 till date. Incidence of treatable ROP has decreased from 10% to 4% from 2015 till now in our database. There are many ophthalmologist-based online surveys for ROP screening and treatment, but to the best of my knowledge, this is the only neonatologist-based online survey done to understand how neonatologist management for premature babies has modified ROP incidence. It is a Google-based survey circulated by WhatsApp and Facebook, done during the month of May and June 2023, and questionnaire was validated by sample survey done by a small group of neonatologists. 24 questions were asked and 46 neonatologists participated in the survey. This is a question circulated. Out of these 46 neonatologists, 12 were from outside Kerala state. 89% neonatologists were from private sector and 91% neonatologists manage level 3 NICU. 50% neonatologists manage more than 10 premature babies deliveries per month. It's a good number. 89% neonatologists have in-house ROP screening facilities, whereas 8% send outside and 2% not do ROP screening at all. 78 never missed ROP screening, whereas 22 missing ROP screening because of various factors. 17% even now not aware of current in ROP screening guidelines of India, and 20% even now following the older ROP screening guidelines, which is a quite big number. 76% neonatologists suggest ROP screening at 1 month of birth, but 24% screening anytime after birth. 56% neonatologists still believe less than 31 weeks of gestational age is the criteria for high-risk premature babies, which is not correct. What current ROP screening guidelines says, all premature babies less than 2000 grams or less than 34 weeks of gestational age should be screened, and first screening should be done before 1 month of birth. High risk preterm is less than 28 weeks of gestation, not 31 weeks, and with multiple systemic factors, ROP screening can be preponed to 2 weeks, but not any time after birth. ROP pathology says that vaso-obliterative phase seen at birth is due to high oxygen supplementation, which take 2 to 3 weeks to reach vaso-proliferative phase after birth, which is the main responsible cause for ROP screening. Thus, ROP usually does not prevent before 3 weeks of premature birth, and thus there is no need of doing ROP screening before 3 weeks until baby has some serious systemic cofactors. 50% neonatologists follow strict guidelines for 7 gram percent hemoglobin for blood transfusion. 28% agree to transfuse blood even at a higher HB of 8 gram percent, but 22% don't know any guidelines for blood transfusion. What guidelines says? Blood transfusion should be done at HB of less than 7 gram percent, but higher risk neonates can be transfused at higher HB cutoff of 8 or 8.5 gram percent. It also says a restrictive transfusion approach should be recommended over liberal transfusion for premature baby, that it usually shut down the bone marrow. Recent up-to-date guidelines, what has been published in NNF and other for pediatricians, says that 7 gram percent is a standard cutoff for blood transfusion, but also says cutoff can be raised to 8 gram percent in infants with multiple systemic risk factors. These are listed in the blue box. Unfortunately, they have not included worsening of ROP as a high-risk guidelines for blood transfusion. 15% neonatologists even now prefer to give 100% oxygen supplementation for resuscitation at birth, which is very risky, while 87 to 90% neonatologists prefer to use room air, blended oxygen, CPAP, neopuff for oxygen blenders for neonatal resuscitation at birth. Various meta-analysis, stop ROP study, and recent NNF guidelines says that high saturation target of SpO2 of 90 to 95% is good for reducing infant mortality, but SpO2 of 85 to 90% should be attained for ROP prevention. It is less than the what we know, everyone knows. It has also been published, recommended by NNF. So study says that babies, that before birth, fetus has blood oxygen saturation of approximately 60%, which increases to 90% over approximately period of 10 minutes, which in a extreme risk premature baby can be done with various methods. This is given by blended oxygen resuscitation with 21% in babies more than 35 weeks, but in baby less than 35 weeks, which are very extreme premature, oxygen, little bit high oxygen of 21 to 31% should be given for resuscitation. And neopuff is a very good method which neonatologists use for with blended oxygen nowadays. There are variable response of neonatologists regarding ROP worsening with various risk factors like days of NICU stay, antenatal steroids, IUGR, hypotension, thrombocytopenia, and hypoglycemia. Various studies also say that these risk factors are not highly associated with risk factors for ROP worsening. Neonatal management in first 60 minutes of birth is called as the golden hour management. Is very important for future premature baby life. And early breastfeeding and good kangaroo care should be promoted for better neonatal survival. So to conclude, 22% neonatologists even now missing regular ROP screening. 20% neonatologists even now not aware of current Indian ROP screening guidelines given by RBSK. 15% neonatologists even now prefer to give 100% oxygen supplementation for resuscitation at birth, which is really very harmful. A collaborative approach by a neonatologist and ophthalmologist is needed for ROP prevention and good infant survival for future. Thank you, sir.
This is important information, but your paper is actually titled Downtrend of ROP Incidence in India.
Yeah, sir, actually, we have seen downtrend, but I studied that and did a survey between the neonatologists. So why we in the awareness? Yes. No, this actually this is not an ophthalmology based survey, sir. So this is basically a neonatologist based survey. It's a probably first survey. It's difficult to understand how
No,
they have.
I understand, doctor.
Yeah.
What I'm asking you is because your title is Downtrend of ROP Incidence in India.
Sir, actually now I cannot change the title. What has been
No, that's fine. I'm just
yeah.
so I just wanted to confirm that.
So it was survey was done after sending the abstract. Pan India, sir, through WhatsApp and Facebook. And I have taken help from the neonatologist of the Cochin. We are screening nearly 20 to 21 NICUs every week, sir. 46 we have done in our study, sir. 46. Neonatologist only. They responded, yeah. No, ma'am, it was not chosen. I made a questionnaire with the help of 3 or 4 neonatologists, and this was distributed with the help of NNF. Whatever reply I got, I did it. So there was a various replies. In Kerala, what I have seen, there is a significant downtrend in ROP. So I was trying to understand why it has gone down in ROP in Kerala. But the way I got the response from all over India, there's a very no, in Kerala, we have seen significant reduction in ROP, sir. Indian incidence is nearly 15. Incidence has come down. Incidence has come down significantly. Both. Both.
In the last how many years have you seen?
Sir, nearly I am doing screening since 2015, and the ROP incidence for both total ROP and incidences in Kerala, I have seen significant downtrend. Nearly 10% of treatable ROP has come down to 4.2%.
So do you think the COVID outbreak had anything to do with that? Because a lot of assisted reproduction programs stopped during that time.
COVID, there was minimal rise, sir. In my table, you saw there was a highlighted thing in between the table. That time incidence got little high, but then again came
because
down in the COVID time.
During COVID, you had less assisted reproduction. So the results you will see a little after that only.
No, we are following that baby, sir. We are constantly following those babies. And luckily, we didn't stop the ROP during that COVID timing also. We are continuing that. Sir, what I feel is here in Kerala, neonatologists are aware they are giving little bit higher, they are keeping little bit higher cutoff for HB transfusion. Strict guidelines, what everyone follows is 7 gram percent, but here doctors are following 8 gram or 8.5 gram percent. They are not using 100% resuscitation at birth. They are using neopuff, what I mentioned, to give oxygen supplementation. So 21 to 30% is their oxygen supplementation, which is reducing the ROP incidence. And periodic follow-up obviously is doing. So, and first golden hour, what I mentioned especially, first golden hour, which has not been documented by anyone, but yes, golden hour management probably is a very major cause even for sudden surprises in ROP worsening. It's awareness basically. It's the first survey I did. Since I have sent the topic, I could not change that.